Okay, so this will be a word round scenario. We'll give a scenario and we keep on asking question, and then you can do the remaining part. Good morning. Today we will have a word round scenario discussion. A case of hematuria will be presented by Dr. Aditi Singh, a second-year junior resident at Howrah District Hospital, and our moderator today is Professor Devanshu Swarkar, who is Professor of Neurosurgery at IPHM SKM Hospital. Aditi, you have a scenario made?
Good morning, sir. Yes, sir.
You made a scenario for a presentation like?
No, sir. I have not made a scenario. I
think Mehul is supposed to make it. Okay, I give a scenario. A 60-year man is coming to emergency with history of hematuria for last 24 hours. So this is a patient at ER and you are the ES on duty. So Professor Swarkar, you can carry on from this point.
Okay. Good morning, everyone. Dr. Aditi is a 60-year-old male attending the emergency with history of hematuria. So what is the exact history you like to want to know from the patient and examine the patient? To start with the history.
we will look for, we will ask for how long hematuria is there. If it's continuous throughout the urine stream, if it's associated with any pain or not, and if there are other symptoms like burning micturition or any hesitancy or nocturia, and then sir we will look for the general appearance of the patient.
History is not complete.
Some more is important.
Hello.
See, whenever you take history, you have something in your mind that this is the provisional or differential diagnosis. So on that basis, you have to ask the patient the relevant histories. So depending on that, he's a 60-year-old male. So you have something in your mind. The first thing you have told that the duration of hematuria is fine. Second is the type of hematuria, whether this is a initial hematuria or terminal hematuria or the hematuria throughout. Second is the amount of hematuria. Because it's just a basic a reddish tinge of blood or it's associated clot. If it is associated with clot, then is there any particular shape of the clot? Suppose the patient has a hematuria from upper tract, there is kidney. Sometimes this patient presents with a vermiform clot, but if the clot is arising from the bladder or the prostate, normally amorphous clot. Okay. So anything else you have asked other than this?
So if it's associated pain, yes sir.
Okay. Can you elaborate? Why do you want to know about the pain and what particular things you ask about pain?
Sir, if it's a painless hematuria in an old age patient, we can think of some neoplasm.
Okay, if it is a painful hematuria, then what are the things you should ask?
Sir, then we will ask correlated with the duration of the hematuria, if it's a recent infection or if there is any history of trauma, or
leave the pain part first. Anything else you ask the patient?
If it is a stone disease, if it is a stone disease,
if yes sir, sir, then patient will have pain, history of similar episodes in past, or if there is urine retention history.
See, the situations where the patient can have a painful hematuria is most common is a stone disease. Okay.
Yes.
Second, stone disease, a patient will have a typical colic followed by hematuria, or sometimes the patient can have clot colic, then colic, followed hematuria followed by colic. Okay. Sometimes the patient will have a RCC or upper tract PCC.
Yes,
this
sir.
patient do not have a typical colic. They will have a stretching pain or dull pain in the loin without any radiation. Or sometimes the patient might be having a stone loss in the intake. This patient will have tract urine. Sometimes the patient will have a bladder stone leading to a hematuria. This patient will have a pain in the suprapubic region, definite features of frequency, urgency, urgent continence. So all these things are very important. You have to have in your mind the differential diagnosis, and based on that, you have to pick all the salient features in history. Okay, so pain is important. Anything else?
Sir, if the hematuria is gross or microscopic?
No, you cannot say
Microscopic will not
microscopic
come.
hematuria.
We told you say hematuria. Patient has seen that. Patient is
Yes.
passing red urine. Don't think of microscopic here. If the patient has got a prostatic enlargement, what other symptom patient may complain of? It's a benign prostatic enlargement or a malignant prostate pathology. What symptom patient may have?
Sir, urine retention history can be there. Patient may have difficulty in urine straining may be present, and the urine stream, decreased urine stream may be present.
Okay.
Then patient may have nocturia frequency.
Okay.
So prostatic
So-
symptom may have some irritative symptom. Some if there is a prostatic enlargement, there may be some irritative symptoms. There may be obstructive symptom.
Obstructive.
What Dr. Sarkar is trying to say, you keep in mind the possible diagnosis the patient may have because of this hematuria, and if you go through all the symptoms at the end, you can make out, yes, this patient has this symptom, so likely this is the diagnosis. That is important. Okay.
Yes, sir.
Okay. Anything else in history? One of the differential diagnosis in early patients having hematuria is just UTI. So you have to ask the features of UTI, whether the patient has any associated frequency, burning micturition, followed by hematuria. So this is very important. The commonest or common differential diagnosis of hematuria in a 60-year-old male patient, first diagnosis unless specified is the CA bladder. Okay. Second is bladder prostatic pathology. It can be a BPH or it can be a CA prostate. Third is the patient is having the upper tract malignancy in the form of RCC or upper tract TCC. Yes, stone disease, UTIs, all these things. So you have to clarify the type of hematuria, amount of hematuria, whether this is initial or terminal or slow hematuria, associated symptoms like pain if the patient has pain. What is the type of pain? It's a pain because of the clot colic, pain because of the renal staging, pain because of this bladder stone. From this pain also, you have some idea what is the origin of the hematuria and associated symptoms like what I have told, rule of UTI or bladder stone. Okay. So some patients will have some advanced disease. Suppose the patient has CA bladder, they will have some advanced disease in the form of systemic symptoms. So while completing a systemic symptom, you have to pick a history of the systemic symptoms also. Low grade fever, weight loss, anorexia, patient has all these things. Okay. And it's very important whether the patient has a past history of any urological intervention or not. Maybe the patient had a TURP before, maybe the patient had a TURPT before the CA bladder. It's a known case of CA bladder. Unless you ask the patient, you cannot be able to give that history. Okay. Anything else in the history? Dr. Aditi?
Yes.
What is the form?
So we will do the PR examination.
No, history.
Hey, don't jump to PR. There are a lot of things to be seen before you go to PR. Because he may have chronic retention because of clot. He can find a mass in the suprapubic area. There may be a renal mass. So
Yes,
go
sir.
systematically. You see whether he is in shock. Patient in hematuria may come to emergency in shock. So start your examination. Dr. Sarkar has another question. Anything else in the history? We have talked about the renal pain. He may complain about mass in the loin, and other symptoms we have asked.
Okay, sir. Patient, if we will ask if the patient has any pain in the loin region or in suprapubic region, if we can feel any mass.
No, you have to ask the patient regarding any mass in the suprapubic area and the loin. Okay. Anything else very important in the patient with history of hematuria? Personal history is very important. Whether he is a smoker or not.
Smoker
Okay.
history, or if he has hypertension,
Yes.
his obese patients.
Okay. Anything else? What is his profession? Because there are few malignancies in man who is directly related to his profession. So CA bladder is one of the things. You have to ask what is his profession. Okay. Family history, is it important?
Sir, yes, sir. Some family history is important, sir. If some bladder cancers are hereditary.
Okay. Is it bladder cancer or is it a renal cell carcinoma?
Renal cell carcinoma.
Yeah, some RCCs are familial. CA prostate is
Renal
familial.
cell.
Okay. CA bladder is not familial, but the incidence is slightly more. Okay, so any history of hematuria, if you think the patient is having RCC or TCC or CA prostate, you have to ask about any history of urological malignancy in his relatives. Okay, so these things you cannot. Personal history, addiction, particularly about smoking, and his profession, family history regarding any urological malignancy is very important in a patient who has dementia. Okay. So from this history, I tell you the history, 60-year male with some amount of obstructive symptoms comes with 2 episodes of painless gross hematuria without any associated dysuria or fever. So now this is the patient. Okay, he does not have any history of family history. He is a smoker since last 20 years. He is a school teacher. He was a retired school teacher. Okay, now what do you want to examine?
Sir, next step.
Sequence of examination.
Yeah.
Go with the sequence examination. Don't ignore the general examination.
Sir, in general examination, sir, we'll look for the pallor and
Yes.
if patient is cachexic, if there is any lymph node enlargement, blood pressure of the patient, general condition.
Okay.
Then we will do the systemic examination. Per abdomen, if we feel any lump in the renal loin region or suprapubic region, and in hypogastric hypogastric region, then next we can go for PR examination. If we can palpate the prostate enlargement.
Okay. If you find the bladder is full in the suprapubic region, what may be your impression? What may be the cause of bladder being full in a patient who is coming with hematuria?
Sir, obstructive
What?
prostatic enlargement.
Apart from that, this happens. Patient having severe hematuria.
Yes, sir.
What else may cause obstruction? It may be a clot retention. Okay. Clot
Yes,
retention may also cause bladder outer obstruction.
Bladder. Yes, sir.
Okay, so in emergency, you have to look for the vital perspective because the patient has come to the emergency with cross hematuria. The patient is stable. Have looked for his abdomen. It is a palpable bladder. You do not find any lump in the loin. If you have done a DRE, it's a grade 2 prostatomegaly and smooth non-nodular prostate. There is no obvious sign of malignancy. So now, what is the provisional diagnosis? 60 years male, gross, total painless hematuria, emergency with a palpable bladder.
Sir, bladder neoplasm.
See, you are a MS student, you cannot say bladder neoplasm. So then examiner will ask what are the types of neoplasm you know in bladder.
First, the commoner cause.
Papillary tumor.
First, think of more commoner cause. A patient with has given a scenario. Patient has some prostatic symptoms, and
Yes.
then he come with hematuria. Patient has got chronic retention, probably because of bladder being full. So think prostatic enlargement first, then go to the bladder carcinoma.
Yes, sir.
See, Aditi,
Yes, sir.
in a male patient, 60 years, if the patient has painless hematuria, the first diagnosis you should think of the CA bladder. Okay, but this patient has significant symptoms of bladder outlet obstruction. Okay,
Yes.
so and the patient comes with a palpable bladder. So your first diagnosis should be prostatic pathology in the form of benign prostatic enlargement or CA prostate, depending on the DRE finding. Okay, so you have to change your diagnosis according to the clinical scenario. Yet this patient has a palpable bladder with symptoms of prostatic pathology. So the patient is having most likely that the first diagnosis is benign prostatic enlargement with acute or chronic urinary retention. You ask the patient whether the patient is having a painful retention or a painless retention. If the patient has a painful retention, it's acute. If the patient does not have any sense of retention, still the patient has a palpable bladder, the patient is having a chronic retention. Okay. But if the patient does not have any palpable bladder or significant voiding history, the first diagnosis should be CA bladder. Okay. And what next? Your provisional diagnosis is a prostatic pathology with hematuria with retention. You do not know whether this is clot retention or a retention because of the bladder outlet obstruction. What next?
So then we will start with the basic investigations.
Next, you keep in mind relief. Is the retention. Next should be your relief. How do you relieve?
Sorry, sir. Next.
Patient is in retention. Okay, before you do any investigation, you have to give relief to the patient because the patient has come for his relief view. So, what is the next step? You're in the emergency surgeon.
Sir, we'll police catheterization or suprapubic catheterization.
You're suprapubic first.
Why do you want to do a suprapubic?
Sir, if there is a need, if urethral catheterization.
You try Polish catheterization, that is right. So we
Yes,
come in the next discussion. Okay, you should try for
Police catheterization.
Yes, and relieve the retention. Okay, you should not send the patient to ultrasound room with his retention and he's having pain. That is not advisable.
Okay.
If he's in shock, you start IV fluid. If you feel his BP is low, you should start him IV fluid. So you do the initial measure.
Yes, sir. Initial management, then police catheterization, then we will go for the investigations.
Okay. There are two scenarios, Dr. Aditi. One is the patient has an acute retention, it's a very painful retention, versus the patient who has a painless retention. Is your management different for both these patients?
Sir, initial management will be same to relieve with the acute retention by doing Foley's.
Okay. You catheterize the patient and catheter print 1.5 liters of. Initially, it was some hematuria. After that, the urine is more or less clear. So you know that this is not a clot retention. It was retention because of prostatic outlet of the bladder outlet. So in an acute retention versus the chronic retention, does management differ or same?
It differs depending on the next. If it's an acute setting, then we'll go for uh, pain management. Uh,
For the residents, just let me clarify one thing. The events after catheterization in acute retention and chronic retention is totally different. If an acute retention, you can just catheterize the patient, relieve it, and discharge the patient home. But in any patient, you suspect the patient is having chronic retention, the patient has a chance of decompression hematuria, and the patient might go
yes,
into
sir.
post-obstructive diuresis leading to hypovolemia or dyslipidemia. So you cannot send any patient home after catheterization if the patient is having a chronic retention. That is not related to the case, that is for your a practical purpose in your day-to-day life. Okay, fine. You have catheterized, he has drained, the patient has acute tension, some amount of hematuria is there, but stable. Now what?
So we'll go for the radiological investigation, basic investigations first, like urine examination, CT scan, USG,
No, don't get
X-ray,
confused.
KUB.
CT scan. Don't come to
Don't
CT scan
get
first.
confused.
Basic investigation, yes.
X-ray, KUB.
Basic investigation, if you are saying that, you complete it. Patient, you said patient may be infection, patient may be diabetic, a 60-year gentleman. Everything should be done. If you say basic investigation, talk to that. Then
Then
come
we'll
to
go.
CT scan. CT scan is the first, not the first investigation. Ultrasound is a very good investigation.
We'll start with CBC, sugar. If there is any urine examination, if there is an RBC or uh, any other cell or uh, culture of the urine.
Urea creatinine, you should mention that also. Urea creatinine, patient having
Urea
chronic
creatinine.
retention.
Yes.
See, there are two
Blood
things.
urea,
Yes.
creat clearance, GF.
Aditi, there are three investigations which you want to know the status of the patient, and there are three investigations which are needed for your diagnosis, specific diagnosis. For the status of the patient, you need to know what is the CBC of the patient, what is the sodium, potassium, blood glucose level,
Yes.
urea creatinine, and sometimes LFT also. So this is for the patient status and urine analysis whether the patient has an urine infection or not. Okay. And ultrasonography of the full abdomen, we should not say KUB. When the patient has hematuria, you should always tell it's ultrasonography of the whole abdomen. Special interest of the KUB because the patient is having hematuria. Okay. So these are the basic investigations you should do in a patient with hematuria. Okay.
Yes.
What about the PSA? It's a 60-year patient and you have a diagnosis, differential diagnosis of CF prostate. You want to do a PSA right now?
Yes, sir. So if it's more than then we'll have to.
I'm asking whether you want to do a PSA right now or not.
Yes, sir. I want to do the PSA.
Patient
Why?
having retention, patient
Yes,
having
sir.
some amount of infection may have
Yes, sir.
mostly elevated PSA.
See, in any emergency condition, if the patient has some suspicion of UTI or patient has retention or even the patient does not have retention but you have to catheterize the patient for other reasons, do not do a
Yes.
PSA in that setting. Because these are the situations where the PSA might get elevated fallacious. So if you need a PSA in this patient, you have to do it approximately 3 to 4 weeks after this incident. Okay, not now. This is the misleading question the patient examiners might ask you. So no, sir, I will not do PSA right now because the patient has retention and probably he might have UTI also. So I'll do, if it's needed, I'll do it later. Okay, fine. So the scenario is the patient urine is RBC plenty, pastel 5 to 6 per hydroxyl pill, hemoglobin is 9, TLC is 12,800, creatinine is 1.2, urea is normal, sodium potassium is normal. And USG, there is some clot in the bladder. Upper tract is normal. Upper tract means both the kidneys and ureter are normal, but there is some clot in the bladder. Prostate is 45 grams. Now what?
So if there is clot in the bladder, then we'll have to do bladder wash.
There is a clot. I don't know what is clot or something else. There is something looks like clot in the bladder. There is no obvious mass. Okay. Other hemoglobin is slightly low. PLC is raised to 12,800. But urine analysis seems okay from infection point of view. Next one.
So I think you should consider the scenario given by Dr. Sarkar. It's a scenario of a benign prostatic enlargement with some clot in the bladder. And hematuria probably due to BPH. So what should be the management from this point? And patient has also the infection also.
So then
What?
we will go for medical management initially.
Okay, what medical management? Are you satisfied with your diagnosis?
No.
Yes, the first diagnosis is definitely prostatic pathology with bladder outlet obstruction leading to acute renal retention and hematuria. Fine. Then what? Any other differential diagnosis?
So it can be UTI.
Can be
UTI.
UTI. Yes, it can be. Anything else?
Any bladder pathology?
CA bladder.
Yes, that is also a possibility because elderly patient with history of smoking, history of painless, gross total hematuria, CA bladder is definitely a possibility. Okay, then what next? What is in your mind? What next?
Will you consider operative intervention or like to treat the infection?
No, sir. First, we'll go for medical management. First, we'll try for medical management, sir.
What medical management?
IV fluid. We'll give the IV fluid, antibiotics, pain management, and we can use usually alpha blockers and 5-alpha reductase inhibitor drugs can be used.
What are the concerns in this patient? What are the concerns?
Got the point? What is the concern in this patient? If we talk of BPH and hematuria, it is very serious concern. Apart from that, what is the concern? The concern is they should not miss a associated bladder pathology. Okay.
See, BPH present with hematuria and clot retention, yeah, can happen. But whenever any elderly patient comes with hematuria, you have to rule out CA bladder or any upper tract pathology, RTC or TCC of the upper tract. That is the main thing. Here you have a patient 60 years with history of hematuria. The patient has some clot in the bladder. You do not know whether this is because of UTI or the clot, a small tumor is hidden inside the blood clot. So you have to be doubly sure before you give a medical management to this patient. So for the patient, concern is hematuria and he cannot void. For you, concern is main concern is hematuria because you have not diagnosed the hematuria part yet. Okay, so medical management, yes, you have admitted the patient, you have sent a urine culture, you have to put the patient on antibiotics. After 3 days, the patient is passing clear urine. The urine culture comes sterile. What next?
So if the urine, then we'll go for if medical management fails, then we'll go for surgery.
No, no, it has not failed. No hematuria now. Infection has controlled. So your medical has worked. Now there is still a concern. Will you discharge the patient or need to do something else? That is the question now.
Sir, we'll repeat the ultrasound to check for the.
Okay, same finding. Ultrasound is not needed because you have a baseline ultrasound. It is done in your institute only. Okay, if you do the same finding, a mass-like thing, whether it's not, you do not know the clot or something, you can instruct to the radiologist colleague while doing the ultrasound. How to differentiate a clot and a mass?
The clot will be irregular.
Mass can be also regular. The radiologist can do two things. One is change the position of the patient. Normally, if it is a mass, it is fixed to the wall. You should not change the position. If it is a clot, mostly clots are mobile. To change the position of the patient, clot will get displaced and change the position. That is one thing. And second is the radiologist can do a Doppler. If it is a vascularized mass, probably it's a mass. If it is not showing any vascularity inside it, it's a clot. Okay, these are clinical things or radiological things you can do. So the radiologist has reported some amount of vascularity fixed to the wall. What next? Patient is stable, no hematuria. Day 5 after admission, patient is on campsilocin and rituximab. What next?
Then we'll go for operative treatment for removal of that mass.
You are not sure whether the patient has mass or not. What about the obstruction? The patient is on catheter. He says, doctor, I don't want to be on catheter. Either you operate on me or you remove the catheter. Which one you will do?
Sir,
So this is a patient who has some amount of voiding symptoms with history of one episode of hematuria. Okay, you are sure that the patient does not have any chronic retention because it was a painful retention. You have done an USG, there is no upper tract changes in the form of hydroerythronecrosis. Creatinine is normal, so no, it's acute retention, it's a chronic, not a chronic retention. So this patient is fit for a trial without catheter. I'm talking about the bladder outlet obstruction. Okay, so day 5, the patient is stable, is on alpha blockers. You should give a trial without catheter, that is catheter removal trial in patient. Okay, that is one thing, that is for the bladder outlet obstruction part. But for hematuria part, investigation is still not clear. So what investigation should do?
sir, renal arteriography.
Renal arteriography, why? You don't get confused. You will do a CECT, KUB with CT urography. What idea in your mind? In a
CT
patient who has
urography.
hematuria, which is not delineated on ultrasound fully, you have to do a CECT, KUB with CT urography. Why?
Okay.
Okay. The reason is ultrasound is not very sensitive for detecting any small renal mass, or if you have a thesis in the upper tract, and sometimes it's very difficult to know whether there is any small lesion in the bladder or there is any wall thickening. So if the ultrasonography is not decisive, and the patient has history of hematuria. It can be a one single type hematuria. You have to do a CT urography. Okay, so you have done a CT urography that shows a clot inside the bladder. What next? And you have done, you have given a catheter fit trial, and the patient could void with some difficulty, but he is voiding. What next?
So then, if we are seeing clot, then we have to remove it.
How?
Transurethral removal.
Okay. What is in your mind? Still, you have some doubt that the patient might be having a small tumor in the bladder. Okay, that is the main thing. You have done a CT urography and you have almost ruled out the patient does not have any pathology in the upper tract, in the kidney or the ureter. Okay. Then the next investigation should be you do a cystoscopy, clot evacuation, and you do a thorough examination of the bladder, prostate, and urethra to look for any bladder pathology. Okay. So this is one scenario. The next scenario can be you do ultrasonography and you see a 3 to 3 centimeter tumor in the bladder. That is second scenario. Third scenario is you have given a catheter fit trial, the patient could not void. And I will give a fourth scenario also. You have done a cystoscopy, you do not find anything except prostatic enlargement, patient goes home and comes back again with recurrent episodes. Okay, these are the scenarios that can happen. So tell me one by one. First thing, you have given a trial, nothing is there. You do a cystoscopy, there is a small tumor. What you will do?
So we go for this transurethral resection of the tumor.
Transurethral resection of the bladder tumor.
Or sir, open, if it's in bladder, then open excision.
No. First, stick to your duty. Get the report. View the report.
So you should never tell in exam that sir, I will do a open excision of bladder tumor because that tumor becomes a T4 stage. Okay, never do that. That is the reason if a patient comes in the emergency with hematuria, do not put a SPC because you do not know the patient is having a bladder tumor or not.
Yes, sir.
If you have done an SPC in a patient with bladder tumor, you are actually making a T4. Okay.
Yes.
So always try to do a parietal catheterization.
Okay. Okay.
So if you find a tumor, do a TURBT. The second scenario is you do not find anything in USG or CT scan. Even then, you need to do a cystoscopy. Okay, because any patient who has history of hematuria and imaging do not reveal anything, the next investigation is you have to do a hematuria. You have to do a cystoscopy. The another scenario I have told you that the patient goes home, you have done a cystoscopy, nothing is there except a vascular and enlarged prostate. Patient goes back home, comes back again after 1 month with history of hematuria. What next?
Then prostatectomy, radical prostatectomy.
Radical prostatectomy.
No, you don't have the diagnosis.
So we check for if it's a benign prostatic enlargement or CA prostate.
So Aditi, why I have asked this question to you is the reason is you should know what are the indications of doing a surgery in a patient with prostatic enlargement with features of bladder obstruction. Tell me, what are the indications of surgery? It is given in very indications of surgery in a patient of BPH.
Sir, if it's
Okay. I'll give you the answers. See, there are some relative indications, there are some absolute indications. So relative indication is patient is symptomatic, is bordered with the symptoms, and is not well on medication. Okay? Either he is not well on medication or he does not want to continue medication. So this is a relative indication. Symptomatic patient who wants surgery because of many reasons. But there are few indications which are absolute indications. The patient comes with those indications, you should not put the patient on medical therapy.
Yes.
What are the things? If the patient has chronic urinary retention, patient
Yes.
comes with hydroerythronephrosis or chronic retention volume is
Hematuria process.
400, 500, or huge retention volume, chronic retention, patient has a raised creatinine because of the retention. That is one indication. If the patient comes with obstructive uropathy, you should not put the patient on medication. Actually, that is contraindicated. The second indication is if the patient has retention, acute retention, you give a trial without catheter, the patient cannot void. So that becomes an absolute indication. That is called refractory urinary retention. That the patient has failed at least one episode of trial without catheterization. The third indication is the patient has recurrent hematuria of prostatic origin. This is very important. Recurrent hematuria of prostatic origin. That means you have ruled out any other cause of hematuria. There is no upper tract pathology. There is no stay bladder. Nothing. So the patient is having hematuria from the prostate only. You need to take it out. So that is the third indication. Fourth indication, if the patient has recurrent UTI, we have diagnosed bladder outlet obstruction in this patient, and the patient comes with recurrent attacks of UTI. That is also an absolute indication. Fifth indication is if the patient develops any bladder stone and you think this stone is not migrated from the kidney. Sometimes a patient has a kidney stone that comes to the bladder 60 ml. That is not indication of PURP. But if you are sure this patient has developed a stone or it has migrated to the bladder years back, now it has become big. So this is secondary to obstruction. The patient is having stone. That's an indication. The scenario I gave you, the patient goes home, again comes back to hematuria. That puts this patient into the category of absolute indication because of recurrent hematuria prostatic origin. Okay. So whenever you see a patient of BPH or CA prostate, you should look for this absolute indication first. Whether this patient has any indication of surgery, absolute indications, no. Then put the patient on medical therapy. Okay. Sir?
Yes, you have done almost complete. When you give the trial of catheter being off, how long will be the duration of medical therapy? After what period of medical therapy you give the trial of taking the catheter and see whether it can pass urine or not?
So 7 days trial for three cycle.
No, that depends on what is the medication you are giving. So you have the options. You know the alpha blockers. What are the alpha blockers available?
Sir, hello.
You know what are the alpha blockers available for this bladder outlet obstruction?
Yes, sir.
Only?
Like Dr. Deflazacort, Terazosin, or
This is a different.
sorry, sir, Terazosin we can use.
Terazosin. Okay. Anything else? Terazosin is not used now. Used to be used maybe 25-30 years back. So it is the tamsulosin, alfuzosin, or silodosin. So the duration of treatment before you give a trial of catheter free depends on the type of medicine. If you are giving tamsulosin, this is 5 days. If you are giving alfuzosin, it is also 5 days. Some books says 5 to 7 days. If you are giving silodosin, the onset of action is very fast. So even after single dose, that is 5 to 7, 6 hours, you can give trial. But mostly we give a trial after 3 days if you are giving kilo dosing. So your duration of treatment will depend on the what is the drug you are prescribing. Okay. So
Yes.
suppose this sir, do we need to discuss anything about K prostate? Sir?
Now we have done almost the approach of hematuria, how to evaluate a patient, what should the possible cause of hematuria, and then the management. Okay, this is the way we should go for the ward round scenario. Yes, I think we have covered almost all part.
Okay. One thing I'd like to tell in suppose this patient USG shows a 5 into 6 centimeter mass in the lower pole of the kidney. Then what next?
Lower
Sir,
port RCC. Lower RCC, what should be approach for management?
5 into 6 centimeter mass in USG. What investigation will do the next? And what do you want to see?
if there is pus in lower pole of kidney,
The USG says there is a well circumscribed mass 5 into 6 centimeter involving the lower pole of the right kidney. What investigation you should do next?
so CECT whole abdomen.
Okay, what
So
do you want to
CECT
see?
QB.
Okay, fine. So what do you want to see in CCT QB?
So if it's localized and organized, if it's an
See, two things. Whenever you do a CCT, what is in your mind? You need to know.
drain, if we can drain it or not.
No, what do you want to drain? It's a mass. What do you want to drain?
So, we can do percutaneous nephrostomy.
No. There is a suspected malignant mass.
See, the idea of doing a CT scan is you want to know what is the nature of mass. Okay, it can be AML, it can be RCC, it can be a lymphoma, it can be a cyst. Okay,
Yes.
so first, whether you need to be sure what is the pathology you are dealing with. What is the thing you see in CT? By which criteria you can say, yes, this mass is most likely malignant or likely RCC. What is the thing you see? See, this you need to know. If a patient has a mass in the kidney, the most important thing is to see the enhancement. Okay, what is enhancement?
Rim enhancement, if it's there.
And then indicates a vascular mass.
Okay.
The contrast and there is enhancement means it's a vascular mass.
So what is seen is you do a pre-contrast study and look for the Hounsfield unit of the mass. Okay. After giving a contrast in the arterial phase, you look for the enhancement. What is the Hounsfield unit? And what is the difference between this Hounsfield unit or enhancement? So difference in enhancement after giving contrast, difference in Hounsfield unit is called the enhancement. And if it is more than 15 to 20, you are sure this is going to be a malignant mass in the form of RCC. That is the most important thing you should see in CTs. Sir, they are provided with CT plates in the exam. Sir?
Yes.
Are they provided with CT plates in the exam?
No. The ward round, just a scenario given and then keep on asking.
In long case also?
No, even in the case, don't give the investigations. That is only in radiology session. There is a question in the chat box. Dr. Jigara has asked, what is the role of tranexamic acid in control of hematuria?
There's no role of tranexamic acid in hematuria. You need to know what is the exact cause or etiology of hematuria. You should not mask any symptoms. The second problem of tranexamic acid, it makes a very thick clot. Even if the patient does not have any clot retention, he might go into clot retention. So Normally, we do not give tranexamic acid unless the diagnosis is made. You know there is a prostatic pathology, or then you can, yes, you can give, but without diagnosis, you should not give.
I think we have covered the whole part. That is how a ward down scenario goes on. Okay, Aditi, you have gone well, but keep in mind that it should be always a methodical approach to the patient of such patient. Okay, it's a just 10 minutes examination.
Yes, sir.
We have spent 40 minutes, 45 minutes. Okay, thank you. Thank you, Dr.
Thank you, Dr. Prasad. Thank you, sir.
Thank you, Aditi.
Thank you, sir.
Okay.